Hi, everybody. My name is Nicole Cork. I'm the Association Manager of iHEA's activities. Welcome and thank you for registering for today's webinar, Measuring Financial Protection for Chronic Illness in Low and Middle Income Countries, presented by the Financing for Universal Health Coverage SIG. Today's webinar will run for approximately 60 minutes, and we are recording it and uploading it on our website afterwards. Before we begin the webinar, I just wanted to run through a couple of housekeeping items. If you do experience any technical issues during the webinar, please write them in the chat box at the bottom of your screen, and I'll be happy to assist. Everyone on the line has been muted except for the speakers in an effort to eliminate background noise. We ask that you also keep your video turned off to preserve bandwidth. If you do have any questions during the webinar, please use the chat box, and we have left time at the end for discussion. I will now pass it over to Virginia Wiseman, who is the convener of our Financing for Universal Health Coverage SIG, and she will introduce today's speaker.
Thanks, Nicole. Well, welcome everybody. It's great to have so many of you online, especially at this incredibly challenging, difficult time for many countries, many health systems, and many people individually are affected by COVID. So thank you for taking the time to join us. As Nicole said, this is another one in the series of webinars for the Financing for Universal Healthcare Coverage Special Interest Group. And we're really fortunate today to have speaker Adriana Murphy, who is Assistant Professor of Health Services Research and Policy at London School of Hygiene and Tropical Medicine. Adriana has a Bachelor of Arts degree in Social Psychology from the University of British Columbia and also a Master of Science degree in Global Health from Harvard University, Cambridge. She currently holds a Wellcome Trust Research Fellowship at the London School, and the title of her presentation today is Measuring Financial Protection for Chronic Illness in Low and Middle Income Countries. So I'm going to hand over to Adriana, who is going to speak for about 30 minutes, and then there'll be plenty of time for discussion. Thanks very much, Adriana.
Thanks, Virginia. Yeah, I just wanted to echo Virginia's thanks for joining at such a complicated time. And I know I've personally had trouble motivating myself and focusing on my work, but then have been reflecting in the last few weeks on how even more important our topic of financial protection is at this time, particularly when we're already even hearing anecdotal evidence of people all over the world reluctant to seek care because of fear of costs. And I think this might be a particularly difficult issue in low-income countries for those who are already incurring regular costs for chronic illnesses and who lack financial protection. So on that note, what I set out today as the objective for this webinar is to critically analyze some of the implications and some challenges of various approaches to measuring financial protection for chronic illness in low and middle income countries. And I'm going to do so by presenting some of my work and some of work by my colleagues. But I wanted to emphasize that a lot of what I'm presenting is really work in progress. So I do welcome feedback, disagreement, and I think we've allowed quite a bit of time for discussion. So hopefully I'll be able to encourage that discussion with this presentation. I wanted to just give an outline so we know where we're going. I'm going to start by just very briefly reviewing the targets set out for monitoring financial protection that are included in the Sustainable Development Goals. I'm sure we're all very familiar with them, but just to refresh our memory. And I'm going to identify some potential limitations of these indicators for measuring financial protection, particularly for people with chronic illnesses in low and middle income countries. And to demonstrate these limitations, I'm going to discuss some of the findings from my research using different approaches to to address these limitations in low-income country settings. And specifically, I'm going to focus on some findings from our work using data from an international household survey called the PURE study, some work that we've done using household expenditure diaries in 3 low and middle income countries, and most recently, some qualitative interviews that we've done with people in Zimbabwe. As I said, I'm sure everybody's quite familiar with the SDP goals. Of course, I'm talking about goal 3 and specifically target 3.8 to achieve universal health coverage, including financial risk protection. The indicators used to monitor progress towards this target include coverage of essential health services, but also the proportion of the population with large household health expenditures on health as a share of total household expenditure or income. And the measures proposed to monitor these indicators are what is called the budget share method, and they use thresholds of either 10% of total household spending spent on healthcare, or 25% of total household spending spent on healthcare, and anything above those thresholds is considered catastrophic health spending. Some of the limitations that have been identified of these particular measures I've listed here, and these are 4 that I'm going to go through in this presentation one by one. The first is issues of equity, and this is the potential of these measures to underestimate the burden of healthcare costs among the poor and to overestimate it among the rich. Issues around foregone care, so the failure of these measures to account for burden caused by care that is foregone due to costs. The issues around the data collection method used to estimate these measures and to estimate progress towards financial protection, and specifically the limitations of typical methods of surveys used to collect expenditure data and the biases that they might introduce. And finally, issues around coping mechanisms or distress financing mechanisms that people use to finance healthcare expenditure, and the failure of SDG measures to account for the long-term impact of these strategies on households. So while the measures in the SDGs have the advantage of being very simple and straightforward and easy to understand, the argument I'm making is that efforts to monitor financial protection using these measures may not accurately reflect the economic burden experienced by households anywhere, and particularly in low and middle income countries, and I would argue especially for those suffering from chronic illnesses, which of course require long-term and regular interaction with the health system. If we turn first to issues of equity, this is work I'm going to draw on heavily. This is work of my colleagues at the World Health Organization, European Observatory on Health Systems, and the World Health Organization European Regional Office, John and Sarah. They published this paper in the WHO Bulletin, where they outline some of the equity and policy implications of different methods to measuring catastrophic health spending. And they point out that the budget share methods used in the SDG measures, in those budget share methods, the denominator is total household health expenditure. And this assumes that all of a household's resources are available for spending on health, which is a big assumption, of course, particularly for poorer households. And they point out, in contrast, the capacity to pay methods assume that households first have to meet some basic needs before they can spend on health. So ability to pay is defined as a total household expenditure minus some amount corresponding to spending on basic needs, and that amount is defined differently by different methods. In this paper, they propose a measure, and I'm going to refer to it as the WHO Euro measure, WHO Euro approach. and they propose a measure that takes total household expenditure for the denominator minus normative spending on food, rent, and utilities, and they define that as average per capita spending on food, rent, and utilities of households in the 25th to 35th percentile of total spending. And what they've done is, using health expenditure data from across Europe, they compare estimates of catastrophic spending using the different measures, so that among them the 10% and 25% budget share methods from the SDGs, and then this WHO Euro measure that I've just described using normative spending on food, rent, and utilities. And what they find is that the 10% threshold results in the highest incidence of catastrophic spending, whereas the WHO Euro results in lower levels of catastrophic spending than the 10% threshold, but higher than the 25% threshold. And they also considered distribution of catastrophic spending among rich and poor using different methods. And what they found is that using the budget share method, 10 and 25% thresholds, produced an incidence of catastrophic spending that was equally distributed across wealth quintiles in some countries. But in many countries, households in the richest quintile were more likely than households in the poorest quintile to experience financial hardship. And the WHO Euro method showed that the poorest quintile was more affected by catastrophic spending. And this sort of demonstrates that with the budget share method, there's not, once households pass a certain threshold, there's not much visible variation in out-of-pocket spending between rich and poor that captures the disproportionate burden on the poor. So what we wanted to do was to apply these methods and compare the estimates of catastrophic spending we would get in an international survey of countries at all levels of development, where we also have data on health status. So we did this using a study called the Prospective Urban Rural and Epidemiology Study. I don't want to go into too much detail of the pure methods, but you'll see it includes countries at all levels of development, and I've listed them here, and the number of households is over 50,000. Just briefly, in each country, communities are selected to achieve a mix of rural and urban populations while ensuring feasibility of data collection and long-term follow-up. So they're selected to be broadly representative of the socio-demographic composition of communities, and while they're not designed to be nationally representative, their characteristics and death rates have been shown to be similar to national populations. And within each household, all individuals aged 35 to 70 are eligible to participate. Baseline data collection using a standardized questionnaire was conducted in countries at some point between the years of 2005 and 2014, depending on when the country joined the PURE study. And the round of follow-up data that we used on expenditure was collected beginning in 2014. Our analytical sample included households with non-communicable diseases, so that was cardiovascular disease, diabetes, cancer, kidney, respiratory diseases, and that was 17,435 households. We also looked at households separately with hypertension alone and households with neither. And our outcome, as I mentioned, was catastrophic spending. We used as our primary outcome, and this primary outcome has been published, we used the WHO Euro approach. So again, that's looking at per capita health expenditures that are greater than 40% of this basic needs, after basic needs have been removed. So that's total expenditure after deducting normative spending on rent, utilities, and food. And so that, as I said, that has been published, but we've since tried to compare our outcomes using that measure to those using 10% and 25% budget share approaches from the SDGs. I just wanted to point out briefly, this is the sample characteristics of our analytical sample, and I'm showing you this just to acknowledge that our our measures of catastrophic expenditure are somewhat higher, as you'll see in a moment, than what you'd see in the general population. And this is largely because it's a health-oriented survey, but also our population is older. The people with NCDs and hypertension not only are ill, obviously, but they're slightly older as well than those without. And I just show here the mean average age of households in high-income countries, upper middle-income countries, lower middle and low income. And the reference to the paper there is there if you want to look it up. So as I said, we wanted to compare catastrophic spending estimates using the different thresholds. And what I'm showing here is estimates in green using the SDG 10% threshold, the navy blue using estimates with the 25% threshold, and the lighter blue with the so-called WHO Euro method. And much like, this is NCD households only, I should point out. So much like the paper that I just talked about in the WHO bulletin by Silas et al., we did find that the WHO Euro method produced a lower prevalence of catastrophic spending than the 10% threshold. We expected that it would produce a higher estimate than the 25% threshold, and so we're surprised to find this. And I want to emphasize again that this is a work in progress, and we're trying to look at the sample and why what the reasons behind this might be. And some of our thinking is that our sample might in fact be somewhat wealthier than what might be more nationally representative, in fact. But regardless, we see that in lower middle income countries and China, catastrophic spending among NCD households is quite high. And I wanted to just point out, because this will come up later, in low income countries, a lot of people have asked why the prevalence of catastrophic spending is lower than what we see in other country income groups. And we think that that's not an issue of better protection, but more likely foregone care. We also, with Ben Palafox doing this analysis at the London School, wanted to take a look at the distribution of catastrophic spending using the different indicators. And I apologize, it doesn't appear very cleanly there with the labels and the confidence intervals. But again, as expected, we found that sorry, just to explain, we're using here concentration indices with which you may be familiar. The concentration index always lies in the range from -1 to 1, with a positive value or positive or negative value indicating disproportionate concentration of the outcome among richer or poorer individuals. So a value of 1, positive 1, would indicate that only the richest households experience catastrophic spending. If catastrophic spending were not correlated with position in the wealth distribution, then the index would be 0, indicating no socioeconomic inequality. But what we see here is that with all measures, it's concentrated among the poor. It is more so with the WHO Euro method, which again is what we expected. We did not expect it would be more concentrated among the poor using the 25% threshold than the 10%, because it's hard to believe that the poorest, in fact, are even in a position to spend that much on healthcare. But again, we are looking into what this might say about our sample and its characteristics in terms of socioeconomic status. I mentioned that our estimates of catastrophic spending were lower in low-income countries than in lower middle-income countries. And we think that this is an issue of foregone care. And this is the second limitation I wanted to discuss of the SDG measures. So this is, of course, when people choose not to seek care or delay care due to costs. And this is particularly worrisome, of course, when it affects cases that might have been detected or managed effectively earlier. So like in the cases of having had hypertension or diabetes, cases that might have been detected or managed effectively if they were accessing care regularly, but then may end up as an acute and much more costly case, like a heart attack, for example. And what we found, in fact, in the PURE study again, is that foregone care is really a heavily self-reported issue, and I highlighted in red here the numbers for low-income countries, especially among females. This was medication specifically, but we saw similar trends with reporting not accessing healthcare generally, and this is people reporting difficulty paying for medication, and we see almost 43% of females with NCDs reporting that they're having difficulty paying for medication, and almost 40% saying that they simply did not take their medication due to cost. So of course, if they're not taking it, they are not buying it, they're not reporting an expenditure on it, and so the economic impact of costs on that individual and on that family is disguised, and this is not really well accounted for in the SDGs. And I'd be really eager to hear if anybody has any ideas or has come across approaches to trying to better capture this in our monitoring of financial protection, whether quantitatively or qualitatively. Moving on then to the method of data collection, and this is an issue primarily around surveys. That typical methods or surveys used to collect expenditure data may be subject to recall bias. So they often, as you probably know, they often require that participants recall their expenditure from a period of 1 month or 12 months previous, or they're subject to seasonality bias. So if you ask somebody in the summer or during harvest season, that might be very different from a different time of year. This issue has been raised by multiple researchers, and this is one paper that I'm just highlighting by Evelyn Ansa and Tim Powell-Jackson at the London School, where they compared measures of healthcare utilization, so not expenditure, produced by pictorial diaries and household surveys in the same population in a 1 month period in Ghana. And what they found was that self-reported measures of morbidity and healthcare utilization were substantially lower in the household survey than in the pictorial diary. So it raised questions for me about what we might be missing with surveys of expenditure. This is an issue discussed very thoroughly, the benefits or the pros and cons of using diaries instead to measure expenditure by Virginia and Lassong Conte in health policy and planning, and this is what inspired some of the work that I'm about to present. And despite not wanting to talk about somebody else's work when that person's also on the webinar, this is a paper in which they recognize the uncertainty around the use of diaries in low and middle income countries as an approach to overcoming some of the limitations of surveys, and using diaries with 361 diary keepers in the Gambia and 308 in Tanzania. They wrote a paper reflecting on some of the lessons that they learned, some of the considerations that one has to make when applying diaries in low and middle income countries. And some of the key things that they brought up were around the design of the diary. So if using these diaries, for example, in illiterate populations, a pictorial diary might be more appropriate where text diaries are used, there's perhaps a possibility of using a family scribe, so somebody who is able to read and enter amounts of expenditure. Time period is another big consideration, and previous work had suggested time periods of no more than a month, for example. But this, of course, doesn't account for the seasonality issue that we deal with in surveys. And so in this study, they applied their diaries for 12 months to account for the seasonality, which is quite a long time. I don't know if Virginia wants to comment on this later, but I wondered whether this was what contributed to a dropout rate of 20 to 24%. Whether or not that's high or low is not cut and dry, but it is really quite a long time to keep a diary. The frequency of entries was another issue that was raised, and you know, obviously having somebody enter it once a week or once a month introduces some of the issues again with recall bias. So in this study, the expectation was that diary keepers would enter expenditure amounts daily with weekly visits from field workers to remind them to do so. And finally, there were issues around who fills in the diary. So in my own work, I've come across different contexts where in some, you know, it's the women in the household who are much more familiar with what is spent, and some women are not allowed to know what is spent, or the person who is ill is not allowed to know what is spent. So in this case, they used multiple diaries in the house for different individuals to account for all these different roles and different levels of knowledge around what is being spent. But this, of course, required frequent monitoring to avoid double counting. So, as I mentioned, I tried to apply this method with colleagues in South Africa, Moshi and Harare. We, I think, applied maybe a more scaled down version of this because for us 12 months was not feasible. But what we did was ask people with NCDs or hypertension to fill out diaries for 2-week periods 4 times in a year to try to account for issues of seasonality. I'll just show you, we did this in Cape Town, in a township called Langa, in Potchefstroom, both in South Africa. And in fact, the arrow doesn't show, but we also had a rural site in Mount Frere, which is about 5 hours north of Durban in South Africa. We also did this in Moshi in Tanzania, and in Harare and Domboshawa, which is outside of Harare in Zimbabwe. I just wanted to show you the diary that we used in South Africa. We settled for sort of a hybrid pictorial text diary because we did have some participants that had issues with literacy, but we also wanted to have the text there to clarify what the issue, what the item was in case there was any doubt with the drawings that we used. I'll say that I did at one point try to draw this out myself with terrifying results. So we ended up using quite a few images from online, and that seemed to work okay. So as I said, we did this 2 weeks, 4 times per year. We used 1 diary per household, and this was because in some of the piloting that we did, diaries were in fact lost. And so we thought 1 diary per household would be easier to track. Pure, so I should have mentioned this was nested within the larger Pure study sample. So all of these participants are also participants in the Pure survey. And so what we did was that the participant from the Pure survey in the household was the key member responsible for filling out the survey, but they could and most often did seek input from or help in filling out the diary from younger children in the household. And I'm just showing you here a photo of a fieldworker and participant who gave me consent to share this. And this is a fieldworker explaining the diary to one of our participants in Potchefstroom. So one of the advantages of nesting this survey or these pictorial diaries in the PURE study was that now we are able to compare the expenditure estimates we have from the diaries to those produced by the surveys. And this is really early days, so I just finally received the diary data only a couple of weeks ago, and haven't managed to analyze it thoroughly, but somewhat as expected, what we've seen, and this is households with NCDs, across the board, except for with alcohol and tobacco, for some reason. These are the results from Potchefstroom in South Africa. Across the board, what we see is that the survey produces a lower estimate of expenditure on general household items as well as on healthcare related items. We do have more items, but I just wanted to give you a selection. But across the board, the survey produces lower estimates. But I'm wondering now and reflecting on whether the benefit of the possibly more accurate estimate that comes from surveys is significant enough to outweigh what I found to be personally a very resource intensive exercise with the diaries. I didn't mention and meant to mention when I showed the picture of the field worker that this was an exercise that relied incredibly heavily on the dedication of field workers, because in many cases participants were very far from the sort of research hubs or universities where the field workers are based. And phone calls often weren't enough to remind them to fill out these diaries. So they were often making regular visits, which required spending the day to go out there on the bus or in a car, following up families that maybe moved and all that to try to find these diaries was also very intense. And families themselves reported, and this is just anecdotally because we haven't done a systematic debrief yet, but reported fatigue with this exercise. So I'd be interested to hear about other experiences with diaries and issues around trying to reduce respondent fatigue and ensure that follow-up is completed. Finally, moving to coping mechanisms, which is the last thing I wanted to address as a potential limitation. This is around the failure of SDG measures to account for the long-term impact of strategies that households use to finance healthcare in the short term. And here I'm talking about things otherwise sometimes called distress financing or hardship financing, things like borrowing money or selling assets to finance healthcare in the short term. I won't go into detail on this paper just because of time. This is a paper by Gabriela Flores, where they looked at more quantitatively how these types of strategies can impact on measures of economic burden. They discussed how coping strategies can overstate the risk to households' current consumption because that consumption is smoothed, it's protected when households can borrow or sell assets to finance healthcare expenditure. But they then, of course, overlook the long-term impact when that money has to be paid back or when returns from assets are reduced. In India, she writes about coping strategies financing as much as 3/4 of the cost of inpatient care. So this is really not an uncommon issue that needs to be addressed. In this paper, the coping mechanisms that are discussed are primarily borrowing and selling assets. But what we wanted to do in this paper that I'm showing now is to consider what does the research tell us about the range of coping mechanisms that are used. Very often in household surveys, the coping mechanisms included are borrowing money or selling assets, but we wondered whether there are in fact many more coping mechanisms that aren't often captured in sort of very reduced household survey modules, and whether there was any research done on what the long-term impacts, whether either quantitatively or qualitatively, what the long-term impacts are of those strategies on households. So we reviewed qualitative or quantitative studies describing at least one coping strategy for chronic illness in low and middle income countries. We found 47 papers and actually found that these highlighted several coping strategies that are not often addressed in financial protection household surveys, things like taking children out of school, reducing food consumption, reducing medicine consumption, changing labor arrangements to take care of the elderly, or changing labor arrangements, taking on second jobs to finance healthcare. But only 6 studies addressed the long-term impacts of these on households. And I have to say they addressed them, but this was across, 3 of these studies were cross-sectional, so they were addressing them sort of retroactively. Have these things affected you when you've done them in the past? But no study has been longitudinal following households up who have engaged in these types of mechanisms to see what the impact is on health and on livelihoods moving forward. So we concluded that more longitudinal and qualitative work on this topic is needed. In fact, we ourselves engaged in qualitative work to try to get at this topic, and this is something that is really very fresh. So I don't have much analysis to show you, but I'm going to end with this. We've done 50 qualitative interviews with households in Zimbabwe that have reported using some kind of distress financing mechanism to finance chronic illness expenditure. Interviews were conducted by local field workers in Zimbabwe 1 year after the pictorial diaries were initiated, and it was in the diaries that they reported using these mechanisms. And we're doing thematic analysis of the interview data, and to inform the analysis, we're drawing a bit on this framework that was, I think, initially developed by Stephen Russell. It was published in this paper by Jane Gooch, where it talks about the various, basically the cycle of healthcare expenditure and income losses and how that affects the household. And we're focusing mostly on the areas of from box 3, where households manage costs, moving into box 4, manage costs through financial strategies, and the impacts of these strategies can be assessed by comparing changes in household livelihood over time in response to illness, and looking also at the psychological impact, or the impact on health and on poverty and on well-being that these coping mechanisms make, and of course the role that social networks have in the household's ability to cope. And I just wanted to show you, just to finish, one quote that I think, one quotation that I think demonstrates well this issue of the decision, that the impact of healthcare costs on the decision to cope in various ways, and the longer term impact that has on not only health and livelihoods, but also on the exhaustion of social network resources. It's not easy to get cash to buy the medication, since I don't have a job right now. Before, I could sometimes borrow from other people, but now they say they don't have money. I try to sell the produce from our field, but then my family doesn't have much to eat or profit to use for the next season. Like now, it's been 3 weeks since I last took the medication because I have no money to buy it. When I can't buy the medication, I try using herbs like aloe vera or ginger or blackjack, things like that. And we're seeing quite a lot of these types of stories. So I think it'll be an interesting demonstration of how these coping mechanisms in the short term can seem harmless and allow households to pay for healthcare, but in the long term really have a sort of a devastating and lasting impact, particularly where the health care issue is chronic and continues requiring out-of-pocket expenditure in order to be managed. And I think I'll end there. Sorry, I've gone a few minutes over.
Thanks so much, Adriana. That was very interesting and super clear. Thank you. I can see that there are a few questions popping up. Are you comfortable just handling those?
Yeah, I'm just trying
and
to
then
see.
if
Oh,
we
here
get
we go.
more, we can maybe give people a chance to speak. But let's just perhaps focus on the chat box first, if that's all right with you.
Yeah, so from Laura, are you somehow taking into account that there's underdiagnosing of chronic illnesses among the poorest? Could explain part of your surprising results. Yeah, for sure. Definitely with the lower estimates of catastrophic spending or of health expenditure generally in low-income countries, there's probably a lot of undiagnosed hypertension specifically. One of the things with the PURE survey is that it in fact measures blood pressure, and so identifies a lot of people with hypertension, but often for the first time. So they will not have incurred health expenditure simply because they don't know. And levels of unawareness are huge. We actually, not me, but the PURE study actually published a paper on levels of unawareness and untreated hypertension across the board, and in low-income countries it's very high. So yes, definitely, that's a good point. And then, do you consider impoverished healthcare or health expenditure and poverty gaps from health expenditure as supplement to catastrophic healthcare expenditure measures, as this measure would be better at capturing the issue around the poverty line? If you're talking about impoverishment, yeah, we did. So in the paper that I mentioned in BMJ Global Health, we've published, it also includes impoverishment, which is less common, but still prevalent. And we also in that paper included those who are immiserized, so those who were below the poverty line to begin with and then have become even more poor. So they have sort of a negative proportion of healthcare, of their budget spent on healthcare, and so they are captured and published in that paper. And I'm trying to see, I am sure you have thought about this, but how do you handle the fact that some NCDs, say blood pressure and diabetes, could be associated with other comorbidities causing higher medical spending? If you mean NCD comorbidities, we would assume that that's still NCD related spending, but obviously with other comorbidities like mental illness and stuff, this is an issue that we would like to better tease out, and I think we're in discussion right now with the teams that collect the data on the PURE study about trying to collect better data on other comorbidities, because yes, definitely, it's a huge limitation of what we've done, is that we're assuming the healthcare expenditures for the NCDs. Hold on a second. This is from D. Govindus, just checking what percentage of participants in the study had access to free. So I don't know the percentage, so access to free NCD care and treatment. In South Africa, for instance, public healthcare facilities provide free care. What was the healthcare expenditure in these settings related to? That's a very good question, and it's often a question that we get, and something I was considering, because in theory, people are supposed to get free healthcare in South Africa. The issue is that often there are very long queues. There are often stockouts of medicines, and people may have to seek care at places or seek medicines, for example, at places where they're not able to get them for free or to travel. And so a lot of the healthcare expenditure was around medicines or consultations that weren't in public clinics. And it's in fact, because I was also surprised by results in South Africa around healthcare spending, it's something that I've tried to or I'm trying to apply for more money to look into a little bit more deeply, because I think it's more nuanced than what I can say with the quantitative data I have now. Given that impoverishing healthcare expenditure rates and gap depth of impoverishment is also routinely now reported in UHC monitoring. So given that impoverishing healthcare data is also routinely, do you also critique these measures? So I think this is similar to the previous question. We did also look at measures of impoverishment using poverty lines. We've actually done a sensitivity analysis using different poverty lines. I didn't want to get into that right now, but I'd be happy to send that to you separately if you wanted to follow up. It's not something we've done sufficiently to present it yet, but it's something that we are considering. It would be good to also reflect on the gaps in the health system to respond to NCDs in the countries where the study is done. Oh, for sure. I mean, this is just one piece of the puzzle. Obviously, financial protection is just one piece of the puzzle. There's issues around awareness, around accessibility and availability of treatment, of medications. There's so many larger health systems issues, and I'm just one member of a larger team working not only with the PURE study, but with research at the London School and health systems and responding to NCDs in low-income countries. And I would happily send some more papers on that if you're curious. And then from Anu, quite curious about the diaries, expenditure like education, clothing, purchase of durables are often are not often, while expenditure on food and other consumables is quite frequent. Yeah, no, this was something we had to consider. If the 2-week period that we choose does not include one of these one-off expenditures, do we simply just miss it? And that was something that we had to acknowledge, that by choosing a rather arbitrary 2-week period, all 3 months apart, that we might be missing these sort of larger one-off expenditures. But we were hoping that what we would be getting is a picture of kind of the more consistent chronic expenditures, like, but you're saying here that the durables are not that frequent. I mean, I'd be curious to hear if you have any experience with how to address that. For us, doing something like a 12-month everyday diary was simply not feasible. So we had to, like I said, sort of acknowledge the limitation that we might be missing some of the more infrequent spending. And Boniface, good presentation and insightful. Thank you very much. It's sort of rushed through those. One thing that I can maybe talk about a little bit more in detail is this issue around the health systems, other health systems factors. And it would be great to hear from anybody else who's doing research on this, but some of the things that we're finding is that obviously, very vertical, non-integrated systems that rely heavily on secondary or tertiary care are worse for early detection and effective management of chronic illnesses. And there's a lot of work being done on how detection, diagnosis, and treatment of chronic illnesses can be better integrated into existing programs that do have strong primary healthcare approaches, like the HIV AIDS response in many countries. Because the way it's designed now, a lot of people don't know they have these chronic illnesses until they have an acute episode and they end up in hospital, and that's of course very costly for families, for society, and is more likely to lead to death. But perhaps I could, will audio be available? I missed starting bits. Oh, hold on a second, across the diaries and survey, was there consistency and recall for major spending on, say, hospital admissions? Yeah, so I hesitate to give any numbers right now, but it seems that recall of those major events is consistent. But in fact, Virginia, is something that I'd love to get more of your insight on when we start to have more results from the data. And then Anu, it is possible you consider one of those months for surveys when school enrollment happens, which may also lead to complementary purchases, for sure. And that's actually what we try to do, is sort of consider balancing in each country some of those months, for example, when school enrollment starts or when there are major holidays like the Christmas break. Pre-Christmas, there's always a lot of spending, whereas after Christmas in January, there's much less spending. So we try to balance that by including, or trying not to include only major expenditure months versus non-major expenditure months. A lot of this, I have to say, and this is, I mean, I've been thinking a lot about this diary approach, and frankly, the question of, is it worth it? Because it's, a lot of the data collection ended up having to be pragmatic around when field workers had the time and the capacity to reach the households. In Tanzania, for example, in Moshi, a lot of the rural households are located in places that are very difficult to get to when there's lots of rain. And so there were a couple of months in which we had set up our 2-week period of data collection, and then simply had to delay it until they were able to access those households. And these are field workers that frankly have quite a lot of other data collection that they're responsible for. And I wonder too whether that was something that needs to be addressed if this is ever attempted again, that data, that the field workers would need to be people specifically committed only to this activity. I think, one last question from Anu. Do you incorporate use of Indigenous health services? Yeah, so we put, I've got also alternative medicines, but I didn't put that up on the slide because I don't have that in the pure survey. I have that in the diaries, but I don't have it in the pure survey. And actually, I would say that that was one of the advantages of the diaries, is that in designing them and in piloting them, we got to learn a lot about the sort of specific contextual sources of expenditure, both health and non-health in each country, that I think often, again, doesn't get captured in surveys. Often surveys will have, you know, maybe a spot for some sort of additional local, very frequently purchased item. But there were a lot of things that the survey didn't include that we learned were actually major sources of expenditure for people. For example, gifts, large sums of money paid when there's a family or friend's funeral, or family transfers, which are not uncommon in low and middle income countries, or maybe in high income countries as well, depending on the family. And so these are things, yeah, that we did look at in the diary, but I didn't put them up on the slide because I can't compare them with the survey. But I should say that one of the main objectives of this whole piece of work, and specifically of the diaries, is to hopefully work towards some perhaps improved data collection method for measuring financial protection that might be perhaps more comprehensive. Whether it's a diary, I don't know, but even a survey that includes more detailed questions. The problem is, of course, that surveys are done in situations where you want data quickly, and there's always hundreds of questions already. We can say that for the pure study, there's so many different modules on different aspects of health So it's hard to find a balance between capturing everything and being feasible. Khurshid Alam, are the data sets of peer study available to researchers? I'm afraid not, and that's I'm not the PI. The studies run out of McMaster University in Canada in Hamilton, and the data sets are not publicly available at this time, and that is because the data is ongoing. It's a longitudinal study. The data collection is ongoing, and the idea is that the countries collecting the data, and that's been the case with all of our papers, that countries are, the country PIs and those involved are authors. The idea is that the countries should have access to the data first to publish papers. But I know that the study is open to researchers contacting them with ideas for analysis and requesting access, but that's addressed on a case-by-case basis, and I have no authority over that.
Great. Any final comments, Adriana?
No, I'm just, I'm really glad for this opportunity, and I should have put my email address or Twitter or something up on the slides, because I'm being quite genuine when I say that this, you know, this was something that I think, you know, more heads are better than one, and it's something that we're working on. But it'd be great to hear about your thoughts. Yes, I'll share it in the chat.
And for those that look at the slides, the publications will also have your contact author details on those as well.
And the Twitter is at.
Okay, fantastic. Well, it's taking me back a long way. I mean, that work that we did on the diaries was well over 10 years ago, but I completely agree with your comments about the challenges of sort of doing this on any kind of significant scale. It is incredibly resource intensive, but it can be sometimes a useful way of doing this sort of work within a subsample and comparing. And if you're willing to accept that this could be something close to a gold standard, and you know, there could be a discussion around that, but I think a lot of people feel that diaries do give quite rich data, whether you know, using it sort of as within a subgroup to see how a larger cross-sectional survey is working. I mean, that can sometimes be a useful thing to do, but it is it certainly does take a good chunk out of your budget. I'm seeing lots of thank yous. That was a really wonderful presentation, nice and open, and gave us lots of opportunity to quiz you. So thank you very much, Adriana, and thanks to everybody who joined us.
Thanks a lot to everyone. Thank you for the opportunity.
Thank you. All right. Okay. Take care, everybody.
Bye.
Bye.